Hey guys, this is Abhijit Barai. In this video, I'm going to talk about pediatric sedation. Especially, I'll give emphasis to the way we do it in our hospital, in the emergency department. So, pediatric sedation can be the most exciting part of the work in the emergency department. It is not only about sedation of the child, but also about the management of the parents. Sometimes they can be more difficult for than the child itself. Also, there is management of the wound in a child that can be a little bit different than from the adults. So it's a broad picture rather than just the sedation itself. But because the topic is pediatric sedation, so I'll focus only on the sedation component rather than the management of the whole scenario. Now, I'll be very honest with you that I do not have any financial interests. I'm a poor guy. I do not have any investment to the pharmaceutical companies. So I have nothing to declare really. Now, who does not like a happy child? I mean, look at him. I mean, he looks beautiful. The problem is in the emergency department, we don't see this type of children. They prefer to stay at home with their parents, with their siblings, maybe with their friends in the school. So they don't come to the hospital. They don't come to the emergency department at least. When they come in this condition. So this is a little Tom who was having some adventure with his newly bought bicycle. He was not wearing the helmet, and things did not go very well. So he injured himself. He has got some injury to the leg. He has got some injury to the head. He's got a little cut on the fingers. So he's not a very happy child. So our challenge in the emergency department will be to convert Tom from this state to this state. And that may be challenging, but also sometimes it can be quite rewarding as well once we do the procedural sedation and manage the wound if there is any. And usually the child will be a very happy person. So when they leave, they will be in this state. But when they come to the ED, they are. So in this video, I'm going to talk about this pediatric sedation. And before I go through the further details, let me show you a little cartoon.
What's going on? Aren't you supposed to be at daycare? I escaped. What happened to your arm? I finally stood up for all of us and told Miss Emily we should be given a proper lunch, not just what's left over from her Baja Fresh. She said I shouldn't raise my voice and pulled me really hard into the other room, and my arm came out of its socket. Are you sure? Are you sure you didn't just sleep on it, Funny? Does this look like I slept on it, Funny? I'm gonna tell Mom. Mom! You are not going anywhere. I finally have a date with Miss Emily tomorrow, and I'm not going to let you or anybody else get in my way until I have seen every inch of her naked. Do you even hear yourself? And what am I supposed to do about my arm? I'll just pop it back in. You most certainly will not. I need to go to a hospital.
Ryan, is Stewie in there with you?
Mom! We're in here, Lois. He's napping. Relax. I'm going to pop it back in. Get in there. Come on. Hold still, Stewie. I'm not saying I like pain, but I'm not saying I don't like it either.
So we can do this shoulder manipulation in a little bit more civilized way, and that is what we are going to talk about. So any injury, shoulder dislocation, or a broken bones in the elbow, wrist, or somewhere else, we can do this under the sedation, and that will make the child comfortable. That will also be less stressful for the parents. I think that is very important. There are a lot of different policy and pathways in the emergency department where I am working at this moment in Christchurch Hospital. And in case of the procedural sedation of the kids, also there is some pathway, and I'm going to talk through that. This pathway was prepared in 2012, so some of the areas might need a little bit of modification or needs to be changed a little bit. Anyway, So this document was prepared on the basis of the guidelines from the College of Anesthetists and College for the Emergency Medicine. So there are a few steps, and I'll talk about step by step. So it's a very busy emergency department, and getting the appropriate staffing and the resources can be quite challenging. So the first thing first is that we need to talk to the ED SMO or the consultant, and also we need to talk to the nursing manager. When we get the approval from them, then we can be rest assured that there is adequate staffing and resources available. Without the adequate staffing and resources, it may be very, very challenging to do the procedural sedation in a child. Second thing is we need, when we talk about the staffing, we need at least 2 doctors. One is for the airway, and the second doctor is for the procedure itself. However, sometimes we might need more than 2 doctors, sometimes 3 doctors, maybe even 4 doctors. Depending on the airway, depending on the type of the procedure that we are going to do. Nursing staff wise, we need at least 1 nurse, but sometimes ideally we should have at least 2 nurses, one for the airway support and the other one is for the procedure itself. For example, some dressing change, or we might need someone to put on a plaster. So we need at least 2 doctors and 2 nurses basically. So this is the in the Australasian College for Emergency Medicine. We do not have any specific guidelines for the pain management and the sedation. But there is one guideline from the College of Anesthetists that we borrowed, and we use it as an endorsed document. What it says is that if we use nitrous oxide or methoxyfluorine, then that's fine. There is 1 doctor and 1 nurse. That's all right. However, if we use sedation, for example, propofol or ketamine or thiopental sodium or other intravenous anesthetics, then we need at least 2 doctors and 2 nurses or proceduralists, sometimes more than that. So that is a minimum requirement, right? So when we get the approval or authorization from the SMO and the nursing manager, then we need to consider about the location. Usually it is done in the resource 1. However, in exceptional circumstances, we may do it somewhere else. The reason we have chosen resource 1 is because there is all the equipment necessary for the sedation. If things don't go well, for example, if we need to do intubation, all the equipments are there. If there is a cardiac arrest, there is a defibrillator there which may be used. And this particular room is also isolated from the rest of the department. So when we do the procedural sedation with ketamine, when the child gets awakened gradually, they need a quiet environment. We need to turn off the light. We need to keep it a very quiet condition so that they can recover well. Otherwise, there may be some adverse reactions. So that's why we have chosen resource 1. But as I've said that in exceptional circumstances, it can be done somewhere else. Timing is very important. So one thing is between midnight and 8 o'clock in the morning, there is no consultant cover from emergency department. That's why this is the time when the procedural sedation should not be done. However, if the registrar has got enough anesthetic experience and the ACNEM is happy, then it may be done at after midnight as well, but that is very rare occurrence. Fasting is important. One of the complications with the various types of anesthetic drugs is that they can cause vomiting, and that can post the child at higher risk for aspiration. That's why we need at least 4 hours of fasting in a child for solid foods and at least 2 hours of fasting for liquids like drinks. Consent is very important, and the hospital has got some specific consent form that needs to be signed, and this is obviously an informed consent, which means that we need to inform the parents and the child if possible. We need to give enough information to them. What are the different problems that can happen, what we are going to do, what are the medicine we are using, what are the different complications. After we finish the procedure, what may be the outcome, and if there is any problem, then what are the things we can do. So this is an informed consent. This is a robust consent process, and that it should be a designated person who spends enough time with the parents and the child to take the consent. So if the consent is not given, unfortunately, we cannot proceed any further. We need to think about the alternatives. One of the alternatives is that we can admit the child under the orthopedic department or general surgical department, and the procedure can be done in the theater under general anesthetics rather than in the emergency department. So that is an alternative. One of the common drugs that we use is ketamine, and when we take the consent, we need to give the ketamine sedation information sheet to the parents so that they can understand what we are going to do and what may be happening after the drug is given. For example, after giving ketamine, the eyes may be open, the child may be talking, but that does not make any sense. Ketamine is a dissociative anesthetic, which necessarily means that the child will be in a completely different world, right? And during the whatever happens during the procedure, the child will not remember anything. So that's very important. We also need to tell the parents about the drooling of saliva, which is a very common problem or side effect of ketamine. And sometimes it can be actually aspirated. Rarely, there may be some respiratory problem. For example, there may be some laryngospasm. And if any adverse event happen, we have got some alternative that we can give some midazolam, or in very rare cases, we might have to actually intubate the child. So we need to give all this information in writing, and also we need to make sure that actually the child and or the parents can actually understand what we are talking about. So these are the possible complications that can happen. For example, there may be hyperactivity or emergence phenomenon that can happen in 1 to 10% of the cases. That's why we need a quiet surrounding so that this does not happen. In case if it happens, we have the alternative. We can give some midazolam IV, 150 microgram per kg, and usually that works very well. In about 5% of the cases, there may be vomiting, and again, we can give some antiemetic like some ondansetron, and that can be controlled. In a rare occurrence of respiratory event, we might have to do back valve mask ventilation. Now, documentation is very, very important, and there are quite a few paperworks that we need to fill up. We need to fill up the patient information form, where we need to document exactly what drug we are giving, when we are giving, what is the amount, who has given it, and who has double-checked it. Similarly, there is a procedural sedation form, which also needs to be filled up, and it has got some specific information, and usually this is used for audit purposes. Also, we have got the procedural sedation information form that needs for the child, but also for the adults. Regarding the preparation itself, which is the next step, the preparation is basically we need to follow the 80-20 rule, which means 80% of the time you spend for preparation, planning, and 20% of the time you just use it for execution, and the execution will be quite a smooth process. So when we do the preparation, it has got different arms. There is a preparation of the staff, there is a preparation of the patient, there is a preparation of the drugs and equipments, and the preparation of the doctor or the proceduralist as well. So with regards to the patient preparation, we need to make sure that we weigh the child, because if we don't measure the weight earlier, it may be difficult later to calculate the dose. One of the trick here is that if we put the date of birth in the Starship Hospital calculator, then it will actually calculate all the necessary drugs that we might need during this process, and we can just use that number for measurement of various drugs. However, if we know the actual weight of the child, then that actually makes the life a lot easier, and that will be more appropriate for the child. Does it make sense? So one of the common drugs that we use is ketamine. So ketamine is given for, if we give IV, we can give 1 to 5 milligram per kg, and after 10 minutes or 15 minutes, if the child moves or wakes up or tries to wake up, then we can give 0.5 milligram per kg, and we can repeat it every 5 to 10 minutes. If we don't have IV access, one of the tricks is we can give IM, that is usually 5 to 7 milligram per kg of ketamine. We can give IM, and that works very well. And if we give IM, we have got enough time, we can do the procedure, but at the same time, we can actually put an IV access, and then we can give IV, the maintenance dose. If things don't go well with ketamine, sometimes, especially if there is some emergency situation develops, we can give some midazolam as an alternative, 150 microgram per kg of body weight of midazolam. Now, with regards to the equipment, there are a lot of different equipments. There are some airway equipment. For example, we need oxygen, we need suction, we need face mask, non-breathing mask, back valve mask ventilator. We need oropharyngeal tube, nasopharyngeal tube, and we need various types of drugs, including the ACLS drugs. And the Starship guideline or the Starship calculator is very helpful in this sense that it calculates all the drugs which are necessary in case of the event of a cardiac arrest, or in case of the APLS or ACLS resuscitation drugs. Now, we also need to keep the defibrillator nearby just in case if there is any cardiac arrest, and we need the intubation trolley near hand so that we can do the intubation if needed. During the entire process of the procedural sedation, there are two things we need to keep monitoring. One is the pulse oximetry, and sometimes we can actually use the end tidal CO2 measurement as well. But every 5 to 10 minutes, we need to check the blood pressure and the ECG to make sure that the child does not develop hypotension. During the procedure itself, obviously we are giving the IV drugs, or we can just give IM. Sometimes, if the IV access is difficult, we can also use the Entonox. We have got an Entonox machine where we can increase the nitrous oxide to 70% with 30% of oxygen, and that works really good. And then, under the influence of that, we can do the procedure and or the IV access, and then the procedural sedation. Now, during this entire process, we need to make sure that we check the respiratory rate, heart rate, oxygen saturation, and if possible, the blood pressure. So this is the nitrous oxide and oxygen tower. The beauty of this is we can actually adjust the percentage of oxygen. So if we put it 100%, then we are basically giving 100% oxygen here. But if we can actually adjust this up to 30%. In that case, 70% will be nitrous oxide. So this blue bar, it will show nitrous oxide. So we can give it 70%, while 30% may be oxygen. And after we finish this process, we need to make sure that we put on 100% oxygen for a minute or two so that all the nitrous oxide is blown away. So one of the side effects with ketamine is that it can cause vomiting. And sometimes can cause aspiration as well. So you need to make sure that the child is nil by mouth for 4 hours at least. And in case of vomiting, we can just put the child in the recovery position and give some antiemetic drug like some ondansetron. That works very well. In case of respiratory depression, we can do the chin lift, and we can do jaw thrust, and then we can do the back valve mask ventilation. In the event of a stridor or airway obstruction, we can do suctioning, and in severe emergence phenomenon, we can give midazolam. Now, recovery is it can be quite tricky if we do it in the middle of the department. But if we do in the resus 1, then we can provide the one-to-one nursing support. And during this entire process, the child is kept in a quiet environment. The lights are turned off, and make sure that during this time we give some further fluid. Once the child is stable enough, we can stop the fluid, stop the oxygen, and give enough time so that the child can wake up. One of the things in this that we might have to admit the child to the PMS, which is the online software for admission. Now we need all these tick boxes to be filled up before we take the decision about discharge the child. First of all, the child needs to be fully alert. If it is appropriate for the age, child should be ambulant, should be drinking, and suitable arrangement exists for the transport home. Also, the child needs to be accompanied by some appropriately accompanied person like the parents most of the time. In case of ketamine itself, we need to make sure that the child is fully awake just before. Not necessarily that it does not necessarily mean that the child will be crying, just like what he was doing before the sedation. But what it necessarily means is that he will be communicative, which is appropriate for his age. There should be no focal neurological deficit, and child should be able to drink, and the observation should be normal. In case of ketamine itself, we need to give the information leaflet to the parents, and we need to tell the parent that the child can eat and drink as tolerated, start with some fluid, and then ice block. And child should be kept under observation for 6 hours. And any type of during the movement or ambulation of the child should be observed for at least 2 hours. And after this, we need to give the information leaflet to the parents again, explain that what to look for, and if there is any concern, they can bring the child back to the hospital or seek some medical advice. So these are some of the references I have used for preparation of this presentation. Now, once we do all these different steps from step 1 to step 14, and the procedure is done, the child will be very happy. The child who was crying initially will be very happy and will say, "Thank you, doctor, and thank you, nurse. Thank you very much."